If your car battery dies, the solution is, well, it's beautifully simple.
Right, you just grab some jumper cables.
Exactly.
Yeah.
You grab a pair of jumper cables, you attach the clamps, apply a direct electrical current, and boom, the engine just roars back to life. It's this purely mechanical, linear fix.
And we really like to apply that same logic to human biology, don't we?
We absolutely do. We assume a direct input will just, yield a direct, predictable output. And that brings us to today's deep dive. We are exploring a really highly specific medical question today.
Yeah, the clinical efficacy of intravaginal electrical stimulation, or IVES.
Right, specifically in treating weak urethral sphincters. And we've got a massive stack of source material for this one. Over 30 randomized controlled trials, systematic reviews from the International Braz J. Ural, Cochrane reviews, and reports from the Agency for Healthcare Research and Quality.
There's a lot of dense data to sift through.
It is, but the mission here is to cut through all that medical jargon across decades of research to determine if applying electrical current to the pelvic floor is, a legitimate cure for stress incontinence or just an overhyped biohack.
Which is a crucial distinction.
Definitely. And for you listening, we're talking about stress urinary incontinence here, or SUI. That's leaking urine when you cough, laugh, or exercise due to a weak sphincter.
And it is incredibly common.
Oh, it affects roughly 8 million women over 65 in the U.S. alone. So the psychosocial burden is just massive. You, or maybe someone you care about, might be silently navigating these symptoms right now.
You're probably wondering if this kind of high-tech clinical option is actually worth the time and money.
Exactly, because when you look at the design of IVES, it basically looks like jumper cables for the pelvic floor, which sets up our central tension for this deep dive.
Is zapping the pelvic floor an effortless shortcut to sphincter strength?
Right. Or is it just a highly engineered, unnecessarily complicated Kegel?
Well, before we could even evaluate if the clinical trials consider IVEs a success or a failure, we first really need to understand what the electricity is actually supposed to do to the anatomy.
Right, the biological premise of it all.
Exactly. And this builds on Olmsted's 1990 integral theory.
The integral theory, okay.
Yeah, so it posits that incontinence doesn't just come from a single weak muscle, but from laxity in the connective tissues and ligaments that actually support the urethra.
Like a hammock that's lost its tension.
That is a great way to picture it. So IVEs works by inserting a probe, which is about the size of a small tampon, and it delivers a pulsed biphasic current to stimulate the pudendal nerve.
So it's directly targeting the nerve to force a reaction.
Yes, it forces a contraction of both the smooth and striated periurethral muscles and the whole pelvic floor. It's designed to increase fast-twitch fibers for sudden stress, like if you sneeze, and slow-twitch fibers for resting strength.
But the sources show a really strict divide in the frequencies used, right? Clinical trials for stress incontinence use a higher frequency, typically around 50 hertz.
Right, to target those weak sphincters.
But then when they treat urge urinary incontinence, which is an overactive bladder, the frequency drops way down to between 10 and 20 hertz.
That's right.
I just want to dig into that for a second because it seems kind of counterintuitive. How does simply changing the speed of the electrical pulse flip the whole physiological outcome from forcing a contraction to, relaxing the muscle?
It really comes down to the neurology, how action potentials work at the neuromuscular junction. So when you apply a 50 hertz current, you're sending 50 electrical pulses per second.
That is incredibly fast.
It is. That rapid firing actually exceeds the muscle's refractory period. The sarcoplasmic reticulum inside the muscle is just flooded with calcium ions.
Okay, so it can't clear the calcium fast enough.
Exactly. Before it has a chance to pump that calcium back out and relax, the next pulse hits. So the muscle is locked in this state of tetanic contraction.
Just a continuous high-tension flex.
Yes, which theoretically targets and builds the fast-twitch fibers. But the 10 to 20 hertz current, that operates on a completely different neurological pathway.
Because it's slower.
Right. It doesn't force that local contraction.
Yeah.
Instead, it targets the sensory nerve fibers. Those signals travel up to the sacral spinal cord and basically hijack the local circuitry.
Oh, wow. So it intercepts the signal.
Basically, it stimulates inhibitory interneurons, which suppress the signals that normally tell the bladder to spasm. It's neuromodulation. It quiets the bladder instead of building muscle mass.
Okay, I follow the logic for urge incontinence. Hijacking the spinal reflex to quiet spasms makes total sense. But let's look back at that 50 hertz protocol for stress incontinence.
The tetanic contraction.
Yeah. This sounds exactly like those late-night TV ab stimulator belts, just applied internally.
The biological premise is identical, yes.
So here's my question. If this device literally forces the sphincter muscles to contract 50 times a second, shouldn't that just automatically build muscle mass and cure the weakness over time, regardless of what the patient actively does?
If human biology operated as a simple linear equation, like your car battery,
Right.
that would be the outcome.
But it doesn't.
It definitely doesn't. When we look at the clinical trials, the data tells a completely different, highly contradictory story.
Mhm.
We hit this massive efficacy paradox.
The paradox being that the forced contractions look perfect on paper.
Right, but while IDES is a proven, highly effective treatment for urge incontinence, that massive systematic review in the International Braz J. Ural found something else entirely for stress incontinence.
Right. They looked at over 30 randomized trials and found, quote, no support for its use in treating stress incontinence, which is just wild to me.
It is a stark conclusion. And it gets even worse when you look at the head-to-head trials.
Yeah, where they compare IVS directly against active pelvic floor muscle training, basically guided Kegel exercises.
Exactly. And in those trials, IVES often produces inferior results.
We're talking about major trials here, too. The GOOD trial from 2003 with 200 women, and the BOW trial from 1999 with over 100 women.
These are not small, insignificant studies.
No. And in these trials, there was frequently no significant difference between the active electrical stimulation and the sham therapies.
The sham being a probe that delivers absolutely no electricity.
Wait, really? The sham was just as good as the 50 pulses a second.
In many cases, yes. Or they found that just doing the active exercises, the PFMT, was significantly better at reducing urine leakage on those standardized pad tests.
So why is there such a massive failure here? I mean, the muscle is contracting. What is going wrong?
Well, there are two major hurdles. First, the methodological one. You really can't meta-analyze chaos.
What do you mean by chaos?
There is no standard protocol. Trials use an infinite combination of waveforms, intensities, and durations. Some run for 4 weeks, others for 6 months. You just can't extract a clear signal from that much noise.
Okay, but even with that noise, if electricity fundamentally built functional strength better than active training, we'd still see a clearer signal, right?
Exactly. Which brings us to the physiological hurdle. Passive electrically induced muscle contraction simply does not build functional voluntary strength as effectively as the brain actively recruiting those fibers.
Because it bypasses the motor cortex.
That's the core issue. Making a muscle larger, hypertrophy, is not the same as functional motor control. Continence requires a highly coordinated, feed-forward neurological loop.
Feed forward, meaning the brain anticipates the need.
Right. When you actively choose to contract your pelvic floor during exercise, the signal starts in your brain, travels down the spinal cord, and recruits muscle units in a synchronized pattern.
You're literally wiring the brain to the muscle.
You're myelinating those neural pathways, you're making the connection faster.
So a passive shock doesn't teach the brain anything. If you're about to sneeze, your brain needs to fire that sphincter millisecond beforehand to maintain the seal.
Exactly. A muscle trained only by external shocks doesn't have that anticipatory software installed. It lacks volitional control.
Okay, so if the data says doing active exercises myself is cheaper and actually works better, why is IVES still FDA approved, covered by insurance, and widely prescribed for weak sphincters?
It's a fair question.
Are we just, throwing expensive technology at a problem because it feels more, quote-unquote, medical?
If we only looked at the aggregate data, you might conclude exactly that. But as we dig deeper into the source material, the data reveals a highly specific, crucial subgroup of patients where this completely flips.
The grade 0 exception.
Yes. For this specific population, this technology is an absolute game changer.
So let's talk about what grade 0 means. Practitioners use the modified Oxford scale to assess the patient's voluntary pelvic floor strength, right?
Right, and more than 30% of women with stress incontinence fall into grade 0 or grade 1 on that scale.
Meaning they basically can't contract the muscle at all?
Grade 0 is an entirely absent voluntary contraction. Grade 1 is just a minimal flicker. The neural pathway from the brain to the muscle is effectively dormant.
So telling them to just do Kegels is completely useless.
Clinically futile. You can't actively train a muscle that your brain cannot consciously locate.
Which brings us to a 2022 randomized controlled trial that focused exclusively on these grade 0 and grade 1 women.
The Ignacio Antonio trial, yes. It provides a crucial shift in how we view this therapy. They subjected this specific group to 8 weeks of IVES sessions.
And the results were completely different from the general population trials.
Dramatically different. After 8 weeks, 36% of the women in the electrical stimulation group completely reacquired the ability to voluntarily contract their pelvic floor muscles.
Wow, compared to only 12% in the control group.
Yes, and it significantly reduced the severity of their symptoms on quality life questionnaires.
So for these women, the electricity actually worked. But how if it doesn't build that feed-forward loop we talked about?
Because for this specific population, IVES isn't the workout. It's the neurological bridge.
A somatosensory bridge.
Exactly. When the current forces that local contraction, it fires sensory neurons back up to the brain. It's providing massive feedback, essentially reminding the brain where this muscle is located.
I love this concept. It's kind of like turning on a flashlight in a pitch black room.
That's a perfect analogy.
Like, you can't navigate the room or exercise the muscle until you can actually see where the furniture is.
Right, you need to map the space.
So IVES doesn't lift the weights for you. It just turns on the lights so your brain knows where the muscle actually is.
Exactly. It helps a disconnected brain find the muscle again. Once they have that volitional control, they can graduate to the active exercises, the PFMT, that actually build the real strength.
Okay, that makes total sense.
Yeah.
But, and this is where the source data just gets completely wild, if the primary benefit of IVES for these patients is just helping the brain feel the muscle, we have to ask a really crazy question.
Is it actually the electricity doing the work?
Right. Is it the electricity, or is something else entirely happening when this probe is inserted?
And this brings us to some really fascinating urodynamic studies, which force us to reconsider the entire assumed mechanism of this therapy.
Yeah, so researchers took 30 women and measured their urethral pressure profile, or UPP, which is basically measuring the raw mechanical force the sphincter can exert.
Right, they measured this under 3 distinct conditions to isolate the variables.
Condition 1, baseline, no probe at all.
Condition 2, the probe is inserted into the vagina, but it is completely turned off. Zero electricity.
And condition 3, the probe is inserted and turned fully on, delivering that 50 hertz current.
Now, based on decades of medical assumptions, you'd hypothesize that the powered probe would create the greatest closure pressure.
Right, because of that forced tetanic muscle contraction.
Exactly. But the results actually challenge the foundational logic of the whole treatment.
They found that just the physical presence of the turned-off electrode inside the vagina improved the closure pressure to the exact same degree as when the electricity was actively firing.
The exact same degree.
I mean, so a piece of unpowered plastic might be doing the exact same thing as a highly calibrated medical electrostimulator.
That is exactly what the data suggests. And it points to a phenomenon known as mechanotransduction.
Mechanotransduction. Okay, break that down for us.
Our tissues are packed with mechanosensory receptors. Things like piezo 1 and piezo 2 ion channels, they detect physical stretch and mechanical load.
So just the physical stretching of the vaginal wall by the probe itself is triggering a reaction.
Yes. When the tissue is stretched, those channels physically pull open. That initiates a cascade of intracellular signaling that can alter local resting muscle tone and fire sensory pathways back to the brain.
Entirely independent of any electrical current.
Entirely independent. The mere presence and mechanical stretch might be stimulating the sensory receptors just as effectively as the high-tech electrical pulses.
So the body is just reflexively reacting to the mechanical geometry of the probe.
Right. And there was a recent 6-week randomized controlled trial that tested this further by comparing traditional IVES against an intravaginal vibratory stimulus.
Mechanical vibration instead of electricity.
Exactly. Which targets different mechanoreceptors, primarily the Pacinian corpuscles.
And what happened?
The vibration group actually showed a statistically significant improvement in pelvic floor contraction strength compared to the electrical group.
Are you kidding? The vibration beat the electricity.
It did. The mechanical vibration was superior at engaging those neuromuscular pathways.
That is huge. I mean, it completely undermines the assumption that the electrical current is the active ingredient for sphincter support.
It forces the medical community to question the whole paradigm.
Is the electricity just a complex, expensive medical placebo for the mechanical stretch?
It certainly implies that treating the pelvic sore like an electrical circuit board might be less effective than treating it like a structural matrix that responds to physical load and tension.
So, synthesizing all of this for you, the listener, we have a very clear map of what this technology actually does.
Yes, IVES is a low-risk, widely available therapy that is absolutely fantastic for urge incontinence.
Right. If you need to relax an overactive bladder, the low-frequency current is proven ineffective. But if you have a weak urethral sphincter, stress incontinence, it is not a magic, effortless cure.
It will not build functional feed-forward strength on its own.
It's true. Proven value lies in helping disconnected brains reestablish a link with grade 0 muscles.
Exactly. It's a bridge so that active training can actually begin.
So if you are exploring this treatment, advocate for yourself. Ask your provider what your baseline muscle grade is, and ensure that any electrical stimulation is paired with active pelvic floor muscle training.
It should never just be used as a passive standalone fix.
Absolutely not.
Yeah.
Which leaves us with one final kind of provocative thought to mull over based on that unpowered probe study.
Or the mechanotransduction effect.
Right. If the physical stretching of the vaginal wall by a turned-off probe improves urethral closure pressure just as much as an active electrical current.
Where does the technology go next?
Exactly. Could the future of treating weak sphincters abandon electrotherapy entirely? Could we be looking at a future that relies on personalized, 3D printed internal splints?
Just designed to apply the precise constant mechanical stretch needed to keep those sensory pathways engaged.
Right, because honestly, it seems like we might be trying to solve a complex problem of anatomical geometry with a battery.
It's definitely a compelling possibility to think about.